Welcome to the main stage for this presentation with Jessica Huber on how Parkinson's can change communication and what you can do about it. Jessica is a professor of speech, language, and hearing sciences and associate dean for research in the College of Health and Human Sciences at Purdue University. In her research funded by the National Institute of Health, Jessica aims to develop a theoretical account of factors that can influence speech production and cognitive change in older adults, both with Ph.D. and without, and to translate those findings to clinical treatment. As the inventor of the Speech Vive device, which you can learn more about at their booth in the Expo Hall, her current research continues to examine the therapeutic outcomes and physiologic effects of a number of speech therapies, including respiratory muscle strength training and Speech Vive. Jessica, I'll turn it over to you.
Thank you so much, Karen. I'm glad to be here, and I just wanted to remind everyone there is a handout of my slides so that you can kind of follow along if you want. And I'm really glad to be here and happy to take questions. And I just wanted to also mention that we have a poll going, a couple of poll questions, get some audience participation here for the talk. I want to start with acknowledgments and disclosures. Obviously, work like this is expensive to do, the work I'm going to present to you, and it's really your tax dollars at work. This is funded by the National Institutes of Health, and a lot of the work that we've done to improve communication in people with Parkinson's disease has only been possible through their funding. I've had lots of assistance from a variety of researchers and many graduate and undergraduate students. And then finally, I wanted to mention my financial disclosure. I receive salary from Purdue University as an employee. I also had support for my salary from my grants. And as Karen said, I'm the inventor and co-founder of Speech Vive Incorporated, which is the company that manufactures and sells the Speech Vive device that I invented. And I'm on the board of directors and serve as the chief scientific officer, and I also own part of the company. So I broke my presentation into two parts. First, I'm going to talk briefly about the impact of Parkinson's disease on speech production, and then I'm going to talk about some different speech treatments for people with Parkinson's disease. So I'm sure this wouldn't be news to many of you. Parkinson's disease definitely affects speech production. We see that about 89% of people with Parkinson's disease will develop voice problems, and at least 45% of them will develop problems with their articulation. I actually think that percent is low. This is an older study that I'm citing here. And what makes it hard for speech pathologists like me and others is that sometimes people with Parkinson's disease don't recognize that they have speech problems. And I hear this from care partners as well. So when I say voice and articulation, I'm talking about these kinds of symptoms. So often we'll hear reduced loudness, so it'll be hard to hear the person with Parkinson's disease. Sometimes there's a breathy or whispery quality to their voice or a hoarse, kind of gravelly sound. Often I hear from patients that it's hard for them to tell jokes and to show their emotions. Their voice is more monotone than they prefer. Often I'll hear patients report and care partners report that their speech is very fast, or what I often hear are very fast speech runs with long pauses. So kind of that's what we would call short rushes of speech. Some patients have disfluencies, and quite often we'll hear an imprecise or slurred articulation. So I wanted to give you some data about this. And so what I'm showing you here is some data about reduced loudness. And my measure is basically a measure of vocal intensity or loudness called sound pressure level. And we're going to talk about this measure quite a bit. And what I'm showing you in the brown bar are age and sex matched older adults who are matched to my patients with Parkinson's disease. And you can see that this measure of loudness is lower in the patient group. And we often see that it's not that much lower from the perspective of the measurements, but it sounds a lot lower to your ear, a lot lower loudness. And what this really, where I've seen this have a big impact, is that people with Parkinson's disease are often older adults, and their communication partners are commonly struggling with some hearing impairment. And so if your voice is quieter, and the person you're talking to doesn't hear as well, that can be kind of a really difficult situation for communication. This is some data that we collected on speech rate, and we measure speech rate in the number of syllables a person can say in a second. And what we did is we followed older adults in brown here and people with Parkinson's in brick or orange here, and we followed them over about 3 years. And so we saw them once, and then we waited about 3 years, 2.5, 3 years, and then we saw them again. And what we saw is early on, people with Parkinson's disease are talking more quickly, but not markedly so. But as we got to the later disease stage, we saw a marked increase in their rate of speech. And what makes this really hard is it's sometimes hard to distinguish sounds and words when speech is coming at you at a very fast rate. And so the listener has less time to comprehend that speech. And so this can be a significant issue for communication. In my lab, we talk a lot about how people support their speech. What are the physiologic ways that we support speech? And your respiratory system is very, very important for speech production. You could think of it as the gas in the car of your speech system. And so what I have here is some data from our lab. It's that same model where we had older adults in brown and people with Parkinson's disease here in clay or orange, and we saw them once, and then we waited about 3 years and we saw them again. And I have two measurements on this slide. One is how many syllables they said on a breath. So you could think of this as how much you could say before you had to stop and take a breath. And what we noticed is there really wasn't a difference early in the disease, but as the disease progressed, we saw a marked decrease in how much our patients were able to say on a breath. That meant they had to take breaths more often. And what that means, if you're taking breaths more often, you have to take breaths in different places than you would if you didn't have to take as many breaths. And what we see is that patients tend to divide their speech into smaller chunks, sometimes not chunks that relate to the syntax of what they're saying, and that can affect speech naturalness, making it hard to understand what they're saying, but also making their speech sound different in a way that is disruptive to communication. And then here's this second graph over here on the right, is looking at that, again, that respiratory system, which is really important. And what we know is that how you use your respiratory system not only changes how successful you are at communicating, but it also changes how effortful speech is. So I was hearing from a lot of my patients that speech was really hard for them. And I wanted to look at why that was happening. And so that's what we are looking at kind of in this study. And what we found is that early on, our patients were starting to talk with more air in their lungs than the older adults were. And that's a really good strategy because there's a lot of non-muscular forces that can be used to speak at higher when you have more air in your lungs. But as the disease progressed, our patients started to, this initiation, the amount of air in their lungs when they started talking went down markedly. And you can see that the older adults, the people without Parkinson's disease, started to have more air in their lungs when they were talking. And so what the older adults did is really efficient. It helps them to communicate with less effort. But what the patients did actually made speech more effortful. And we thought that this was probably related to some of the changes with the disease, some rigidity in the chest wall that was making it hard to inspire and have enough air in the lungs. And I often hear from my patients that they feel breathless sometimes when they talk a lot, and I would be interested if that's something any of you have experienced. So I'm going to move on away from our discussion of how Parkinson's disease impacts speech to what we can do about it, because I think that's more interesting to you and to me. And I think that I definitely want to talk about this, but if you want to talk a little bit more about physiology or how speech changes in Parkinson's disease, I'm absolutely willing to do that at the question and answer. So we're all really familiar with the types of medical treatment that we can that are used with people with Parkinson's disease. Usually it's a drug, Sinemet, levodopa, that crosses the blood-brain barrier and produces dopamine in the brain. And this works very well for limb symptoms and body symptoms related to Parkinson's disease, but it doesn't help speech. We think that it probably doesn't make speech worse, but it doesn't really make it better. Later, as the disease progresses, many patients have deep brain stimulation surgery. And while this treatment can be life-changing for people with tremor or a lot of medication on-off effects, it can be detrimental to speech, swallowing, and cognition. And just to give you a little slide about that, so this is my measure again of how loud a person is talking, sound pressure level. And this is a study I'm doing with a movement disorder neurologist here in Indiana. And what we looked at was we saw the patients before they had deep brain surgery, and then we saw them 6 months after surgery, and they were optimally medicated at both these points. And what you can see is that sound pressure level dropped dramatically. This loudness dropped dramatically as after deep brain stimulation. And we saw other changes to their speech that I won't talk about today, but we do know from a variety of studies that deep brain stimulation surgery can cause speech to become more impaired in some patients. So when we talk about managing speech issues, we can think about this in two ways. We can have a therapy that is speaker-oriented. That means that we're going to change how the person with Parkinson's disease is speaking, either to improve their function or to introduce some compensations that make speech better. These techniques can be very successful, but they require two things. They require that the patient remember to use the techniques that are trained in speech therapy outside the therapist's room, and to be able to accurately monitor their speech, to know if they're using those techniques correctly. We can also do some therapy that is communication oriented, where we're really changing the behavior of the listeners around the people with Parkinson's disease or the environment that they communicate in. And I am really interested in device-driven therapies. These are therapies where we use devices to either help the person speak more clearly, so improving function or having a compensation, but also looking at ways that we can change the communication environment. And so device-driven therapies could either be speaker-oriented or communication-oriented. And what's nice about device-driven therapies is they often require less attention and less memory from the patient with Parkinson's disease to implement them in their everyday life. So the most common treatment for people with Parkinson's disease is the Lee Silverman Voice Treatment Program. Some of you, I'm sure you know about that. Some may know about this therapy. It's commonly called LSVT or LSVT Loud. It's intensive. We do therapy for an hour a day, 4 to 5 days a week for 4 weeks. And we really, really work on using high effort, talking more loudly. And what the therapy program data shows is that talking more loudly can also lead to clearer speech. And there are a lot of techniques that therapists use within the LSVT program to help patients carry this new voice that they have in therapy over to their everyday life. And of course, daily home practice is required with this treatment. There's a pretty large literature to support the use of LSVT Loud. The literature has shown improvements in voice, articulation, intelligibility, and some of the literature shows that the effects can last for months to a year without additional therapy. And what I'm just showing you is one of their very early studies here. Sound pressure level, again, that vocal loudness measure is on, here is what I'm showing you. So this is loudness. Pre is in brown, post is in kind of brick, and you can see that on average, people with Parkinson's disease were louder after LSVT therapy. However, this line that you see is a line showing us the variability around this mean. And so what this tells us is it doesn't work for everybody. So then why might it not work for everybody? Why do we need other treatments? Well, Parkinson's disease is well known to result in problems with self-perception. So people with Parkinson's disease often don't perceive their speech and voice problems as severely as communication partners. They have difficulty knowing how loud they are, or perceiving their speech errors. And this makes therapy really difficult because not only do we have to teach people with Parkinson's disease how to use these techniques, but also why to use these techniques to be able to perceive themselves. And if you remember early on, I said behavioral therapy requires that people are able to perceive themselves accurately. So this could be one reason that not everyone responds to the Lee Silverman Voice Treatment Program or behavioral therapy, is that they don't perceive themselves as accurately as would be needed for that therapy to work. We also have a pretty large literature in Parkinson's disease that compares the types of cues we give patients. And so I'm going to make a distinction between external cues. These are cues that have visual or auditory feedback about a task, from internal cues, the kinds of cues where you have to know something about yourself or cue yourself to guide task performance. And so a really simple example of this is if I wanted to make you take larger steps, I could use an external cue, some tape, have you walk tape to tape, or an internal cue where you are thinking about taking a larger step. And what we know is that external cues are much more effective with people with Parkinson's disease and generalize better to everyday tasks. And we see this in walking, handwriting, and speech. Here's an example of that kind of data. So once again, on my axis, I have here the measure of loudness. And what we did is we had older adults and people with Parkinson's disease talk at their comfortable loudness here in brown, in noise, so that sounded kind of like a restaurant, everyone talking at once, in the orange, the brick color here. In yellow, we have an internal cue where people had to talk at what they thought was twice as loud as they were at comfortable. And in purple here, we have an external cue where we put a monitor in front of them and they had to talk at a specific number that ended up being 10 decibels, or quite a large jump from their comfortable loudness. And what we see is that, and really these were based on speech therapy, we used the twice as loud as comfortable, that internal cue, and this external cue with the sound level meter in therapy a lot. What we don't use is this noise cue as much. And I was really interested in how an external cue that was natural, which is the noise cue, would work. And so what we saw here is that these cues worked relatively well for older adults, a little less on this internal, on the twice as loud cue, but in our patients, the noise cue is markedly better. And so what this taught me is that we really have to be thoughtful about the cues we use in speech therapy, but more importantly, it taught me the value of these natural external cues like noise. And I used that knowledge to help me develop a device treatment called the Speech Vibe device. And what it does is it plays a little bit of noise in your ear when you're talking. It turns off when you stop talking. And what that does is it elicits something called the Lombard effect. And the Lombard effect is something we all have, where we talk louder, slower, and we articulate more clearly in noise. And we do it without even realizing it. And what I found in my studies was that when patients were talking in noise, they found it to be no more effortful than talking at comfortable. And so when we use this device, we set it individually for each patient. We ask the patient to wear it every day when they're going to be communicating in their daily life. And we reset it as the patient improves. And you can see some examples at our website of people using the device. So I don't want to go through all our studies, but we have completed 5 studies and have looked, they were all at multiple sites, and we've looked at about 155 patients. And we've compared them to other treatments, and we have combined the Speech Vibe with other treatments. And one of these studies is still ongoing, where we're comparing Speech Vibe to that field standard therapy that we use a lot, the Lee Silverman Voice Treatment Program. So in all of our studies, we look at patients before and after treatment, with and without the Speech Vibe device in place. And what we've learned is that patients and caregivers both report that communication improves post-treatment with the Speech Vibe device, that we know that loudness and how much a person can say in a breath increases for the majority of people in our studies, that speech rate improves for about 2/3 of the people in our studies. We've seen changes to, remember I talked about the respiratory system being really important for speech and effort. So is the voice box or the laryngeal system. And we've seen changes to both systems that suggest that after using the Speech Vibe, speech becomes less effortful. And we've shown that patients don't adapt to the noise. So I'm going to show you a slide of that where we looked at patients over 6 months. And what we see here, this is again that measure of loudness. And we're seeing that this is, the brown is always without the device and the gold is always with the device. And here's an 8-week difference. And then this is 24 weeks. And what we see is no matter how long the patient's been wearing the device, we're still seeing that they respond to it. They keep getting louder when they're wearing it. But what we see is after 6 months, we're really seeing that the patients train to a louder sound pressure level as well. So we're seeing that the longer you use the device, the more benefit that you get. So moving on to a different treatment that I've studied, I have studied expiratory muscle strength training. Here I have two devices. This is the EMST 150 from Aspire Products. It's a great device for expiratory training. And here's the Power Breathe, which you can buy on Amazon. It's a British company. And this is really for training your inspiratory muscles. And what's important here is that you're training how strong the muscles of the respiratory system is. So it's like going to the gym and doing weight training, but for your respiratory system. And we generally recommend that people do about 25 breaths, 5 days a week. And a speech pathologist can work through this program if you want to use either of these devices. A speech pathologist can work with you on that. But we know that this improves cough. And so this is just a plot to show that after EMST here in the brick color, patients have stronger cough dynamics. Better cough dynamics. So their cough is stronger. We have some data to also show that this improves, that expiratory muscle strength training at least improves speech in people with Parkinson's disease. And so that's exciting. And that what we saw in my lab is that the way they use their respiratory system was more efficient. So speech became less effortful after this kind of a treatment. Let's say you don't want to have therapy. Another suggestion is a voice amplification system, and they sell these, some of them on Amazon. I like the Chatterbox. That's the one I'm showing here as an example, which is not on Amazon. It's at their site, but it's basically a portable speaker that you wear. You wear your headphones and you have a speaker as a battery pack around your waist, and your voice comes out of the speaker pack on your waist. And can be great, especially if you just have loudness issues. So I wanted to talk a little bit about other things we could be doing to improve communication. One is speakers who have some problems with communication can think about the timing of their communication. Plan for your important communication to occur when you're least tired or your listener is least distracted. It's important to choose quiet places to talk, places where the speaker and listener can see each other, because listeners get a lot of cues from watching a person's lips move. And then I always encourage natural gestures, anything that helps you get your point across, whether it's an action gesture or pointing to something or, whatever it is, gestures are great for improving communication. When I work with people who communicate a lot with a person who has a speech impairment, particularly related to Parkinson's disease, I give them some listener managed strategies. I think it's important for listeners to be upfront if they can't understand the person who has Parkinson's disease, to say, I didn't understand that, not to shake your head and not tell them that you didn't understand. And one way to do that is just to make sure you're still on the same topic. So topics often wander around and merge around as we're having a conversation very organically, but just making sure you're on the same topic. I mean, this is good communication strategy, whether you're speaking to someone who has a speech issue or not. But staying on the same topic is important. I also tell them to pay attention to the speaker. And I know that seems obvious, but when we've been married a long time, I know this from my marriage, I have to be honest, not always looking at my husband when he's talking to me or concentrating on him. I feel like that's a terrible thing to admit, but I do, and we all do it. But when someone has difficulty communicating, we really have to focus on them and concentrate on them so that we're sure we're catching what they're saying. And I also remind them, you don't have to hear every word to understand the message. Piece the clues together, use their gestures. But one piece of that I would provide as a caution is if you are a facilitator or a familiar listener who often translates what a patient with Parkinson's disease says to other listeners, make sure you've talked to that patient about the boundaries, what they want you to translate and how they want you to translate. I often see that a patient will say one thing and their care partner will slightly change the tone or the way that they said it. And those are really important to communication. We have to make sure it's okay to change those things. I think it's really important to manage communication breakdowns right when they happen. So speakers have to encourage those of you with Parkinson's disease need to encourage your listeners to let you know if they don't understand. Breakdowns are easier to repair if we do them right when they happen. So pause occasionally to let the listener indicate they understand or ask if they understand. The listener could even summarize periodically to make sure they're understanding. If someone doesn't understand you, you can repeat the message, but I would move quickly. If one or two repeats don't work, try rephrasing it or describing part of it or using some gestures. Now, it might be great to have some strategies with your common listeners, your family members, your close friends, for how you're going to repair communication so that when it happens, you can move quickly into that. And for patients who have very severe speech issues and communication issues, a listener can even repeat sentence by sentence to make sure they understand. I think support groups are wonderful. These could be exercise groups or just regular support groups or communication groups or whatever is available to you. But support groups are wonderful. They give you a chance to carry over and have a natural practice for what you're doing in therapy. They give you a chance to see the techniques that are employed by other people. So let's say your speech therapist told you to talk louder. You might have someone in your support group working on the same thing, and they could show you how they do it. It helps you to see that you're not alone. You're not the only person with a communication problem. And it allows you to get some feedback from people who have the disease about how you're doing. And I also think support groups are wonderful as an opportunity for some educational programming, whether that's a formal education program like what we're doing right now or something more informal. But definitely reach out to your friends who have Parkinson's disease and talk to them. So I just wanted to give you a little summary here. There's many treatments that have proven or have data to show that they actually help people with Parkinson's disease improve their speech, both in loudness, clarity, and rate, and just overall effectiveness. But also some studies have shown that some of these treatments help with how the respiratory system is functioning, which can have a big impact on how hard or effortful communication is. And I've listed some of them here, but there are lots of them. And a speech therapist really can help you figure out what might work for you, but you also should have an idea of what you want to do. Do you want to do a lot of therapy sessions? Do you want to do home practice? Would you rather have a device? Would you rather have, like voice amplification or the Speech 5? Or would you rather work on strengthening your muscles like we have with EMST? And what I think is that these treatments are best used in a mixed way so that we're trying multiple things at the same time to really give you the biggest benefit for the hours you spend. And I also am a firm believer in some trial therapies. So search for a speech pathologist that's open to multiple therapies, that is open to using therapies together, and that is open to trying different things with you till you find the thing that works for you. No treatment works for everybody, and it's important to find what works for you, both from the perspective of your disease, but also your lifestyle and your just personal preferences. And all of those need to be taken into account for a good speech therapy program. So I'm going to stop presenting now and take some questions from all of you. Let me stop this.
Thank you, Jessica. That was awesome. Everyone, please feel free to ask questions. Okay, here's the first one. Does background noise when using a hearing aid accomplish the same thing as your specific device?
That's a great question. And I wanted to say, first of all, that Ashley Lambert has joined us, and she is the Vice President for Clinical Development at Speech 5. She's also hosting our booth here, so the booth is unmanned.
I'm in two places at once.
Oh, okay. I forget we can do that with virtual. But so background noise can help, but with a hearing aid, that noise is going to be on all the time. So it's not going to turn on with your voice and off with your voice. And we don't really know how that works. My gut instinct from the literature is that you will become accustomed to that noise. And that noise so there's two things. You'll become accustomed to that and probably not respond over time as robustly, which means you won't get the same benefit. The other issue with the type of noise that would be coming from a hearing aid is that it's not communicative noise. So the Lombard effect is really interesting. It is a communicative reflex. And so the more the noise mimics noise of natural communication, the better response you get. And that's why the device uses what we call multi-talker babble, which is a fancy word for a bunch of people talking at once about different things and then filtered together. So it sounds a lot like you're at a restaurant and all the tables have their own communication going on, but you aren't part of any of that. And you have been, the Lombard effect has been happening for all of us our whole lives. And so we're really trying to tap into that special reflex when we're using the device.
And just to add to that too, the nice thing with the SpeechVive, I'm a speech pathologist just like Jessica as well. So one of the nice things with the SpeechVive is I can, with my patients, tune it specifically to the amount of speech volume you need to be heard in those different communication situations you're encountering. Whereas with the hearing aid, it might be a happy accident to get that background noise, but I can't tweak it and tune it exactly to your voice volume needs.
Okay. We'll give it another minute or two for questions. I just want to remind everyone to take the poll. It's next to the chat link up above, and that would be extremely helpful for Jessica and Ashley. If you could take that poll. I also included Jessica's email address in the chat. Here we go. Here's a question. Let me just check this out. Let's see.
And just to continue with the email, I get lots of questions from people from around the country about speech and Parkinson's disease, and I'm always willing to answer them. So you're welcome to email me. I'm sure Ashley would be open to that as well. So feel free to do that, but I'd love to answer your questions now too. Okay. Go ahead, Karen.
Paul has a question. PWP often have issues concentrating. Is there an issue of the speaker getting distracted by the background noise?
That's a really good question. And we haven't finished this. We actually are studying that, and we haven't quite finished that study. But when I've been working with patients, that has not been an issue. That's not something they've reported. In fact, it often fades into the background for the people we work with. They don't even notice it after they've been using it, but they're still responding. So when they stopped noticing it, I started to get nervous they would stop responding, but that's why we did that 6-month study, and they didn't stop responding. So I think that I'm not very worried about the attention or cognitive issues, but it certainly would be something to talk to your speech pathologist about.
Okay. And Patrick is asking, is this device covered by insurance?
I'm going to let Ashley kind of handle that because we had a really big launch on October 1st.
We did. So yes, as of October 1st, Medicare has identified the SpeechVive as a medically necessary device. We've been considered a standard of care across the VA system for about 5 years, and Medicare's catching up. So you can actually go on our website now, and there's a form to fill out to start that process. Cost-wise, it's from what Jeffrey Barker's asking, that is the line in the insurance world, we're a manufacturer, not the insurer, is standard copays do apply. So fill out the form. You'll be contacted by a supplier that will look specifically at your insurance coverage and be able to help you with that information. There was a question Kirk Hall had that Jessica, I wanted to make sure you answered as well. Does singing help, specifically participation in the tremble class?
So that's a really good question, Kirk. That that's still being studied. And the studies are really small N, like small sample sizes, just a few people. But the data is starting to be promising that singing is good for you. I don't think it's going to hurt you. And I encourage all of my patients that I work with who like to sing, go sing. Go do the things you love to do. You know, do the things that exercise your voice and you like doing. They can't hurt you, and they're probably, the data is really showing that they're probably helpful. And what's nice about devices like Speech5 or a voice amplifier is you can use them while you sing. So you can do it whenever you want. John is asking when it's best to begin speech therapy, prior to there being a noticeable issue or after. I guess I would like you to have a relationship with a speech pathologist early, even when you aren't having very severe speech issues or even really noticeable speech issues. But it can be hard for the therapist to bill for treatment if you don't have a speech issue present. So you might not be able to get therapy, but getting assessed and talking to that speech therapist is really important to start building that relationship. Ashley, did you have anything to add about that?
Yeah, that's something that I really, as I go around and talk with different neurology teams and practices, what the newer standard of care is and what we really advocate for is really, as soon as you're diagnosed, it's great to be seen by all of that care team, PT, OT, speech, neuropsych, everybody involved, to get those baselines. Not only do speech pathologists work on your voice, but we actually work on your cognition and your swallowing as well. So you're going to get a lot of bang for your buck out of that initial evaluation and assessment, so that we can set your level, so that as things change, we can then work with you, see what's going on, tailor those interventions, and also relay that information to your doctor so that they can follow your care and help maximize your quality of life. We've got a lot of questions going on at the same time here.
Let's see, hold on.
There was one about fish mouth, and I wanted to address that one.
I can't find that one.
From Stephen Bort, I have dyskinesia of the mouth with fish mouth while articulating. I'm short of breath and speak loudly. Can you touch briefly on how to deal with those?
I think that those are very difficult. So dyskinesias are not modifiable through behavioral therapy. That means I couldn't teach you a way to stop that from happening. I assume, Stephen, that you're seeing a neurologist that might be talking to you about some medical management of dyskinesias. And if you're not, I would really encourage you to see a movement disorders doc who can work with you on treatment for dyskinesia. Short of breath and speaking loudly. Often when people have dyskinesias, what happens is not only do we see them in the mouth, but we'll see them in other parts of the body. And what they do is they give you this fluctuating speech. So sometimes you're loud, sometimes you're soft, sometimes you're out of breath because you're not quite coordinating all these systems together. And so one thing that I have done with patients who have that kind of those kinds of symptoms is I've worked on strengthening the respiratory system through expiratory muscle strength training, because not only does that help with the strength, but it teaches a pattern of deep breath in, exhale out against this resistance, which is very physiologic to speech. That's what speech is. And I've seen some good results with that kind of treatment. Obviously, I don't have a paper on that. That's just my clinical experience. So, but that's worked for me, but definitely get to that movement disorder doc.
Okay. Sorry to cut this off. We have 1 minute left. So for those questions that were not able to be answered, you do have Jessica's email. I will post it again. Thank you so much, Jessica, for sharing your expertise and for joining us from so far away. And if you haven't already, be sure to visit the Speech5 booth at the link that was posted in the chat earlier in the session. I will post it again. She's also kindly offered up her email address. So please follow up with her and ask any questions. And have a great afternoon. Bye.
Thank you, everyone.